why don't we, I'll just introduce Dr. Jose, incredibly valued colleague who is a professor of radiology in orthopedics and does all of our fantastic neuroimaging. And thanks for doing this.
Good morning, Alan. Thank you so much. It's my real pleasure to be here today to speak to all of you regarding something that I'm very, very passionate about, which is imaging of peripheral nerve injuries, predominantly traumatic nerve injuries. In creating this lecture, I'm trying to address a broad audience. And so my goals are to start with the basics of imaging when it comes to peripheral nerves, and then work my way up. So towards the end of the lecture, I'll be getting more into what my senior colleagues would find probably more interesting, which is, problem solving in post-operative imaging and what to look for in these complex cases. But to get started, I just wanted to start off with the basics. I do want to give a shout out to my crew at Lennar. We are what I consider to be the jewel of the crown. And so a lot of the cases that I'll be showing were obtained through the Lennar Foundation Imaging Center, where I serve as medical director. And I truly am passionate about this, and I'm available to everyone, either to come and rotate with me to learn about peripheral nerve imaging. Obviously, please refer any cases, and we will make sure to tailor these exams. And as you'll see, a lot of the imaging and interventional component when it comes to peripheral nerve imaging really requires an integrated approach. So it's not just ultrasound or MRI, it's really trying to get as much information as possible to tailor the exams to these patients for the best possible outcome. So in terms of disclosures, I have no pertinent financial or non-financial relationships to disclose, and any copyrighted material that I'll be presented is done under the fair use doctrine for the purposes of teaching and scholarship. I'm going to leave about 5 to 10 minutes at the end of the lecture for questions, but I'm going to try to get through as much material as possible in the shortest amount of time. So I'll discuss relevant peripheral nerve anatomy and specifically address those anatomic features of peripheral nerves as they have implications for imaging. As you'll see shortly, concepts of leakage, the different layers of the nerves will really matter when we're evaluating these nerves, both on ultrasound and MRI, and what we're seeing and how we can classify our injuries based on that. I'll show you the normal appearance of peripheral nerves on ultrasound and MRI. I'll show you the grading classifications of peripheral nerve injuries and how they have evolved and how we use imaging to help characterize this. This is challenging at best, but I'll show you a simplistic way of what I use to try to get to a correct diagnosis. Then I'll show you some examples of how image-guided peripheral nerve interventions can help, whether it's for injections and hydrodissections, drainages, wire localizations, and then intraoperative ultrasound, something that our group has published in the past. And then lastly, perhaps the most exciting part of this is going to be the postoperative imaging. My goal is that by the time we get to that postoperative imaging, the findings will be obvious. All right, so some initial thoughts. So where does this, what is this interest in imaging? Why does imaging play such an important role in these peripheral nerve injuries? It's because to a broad extent, these patients are not optimally evaluated. So patients with traumatic peripheral nerve injuries are not optimally evaluated alone with neurological exam and electrophysiologic studies. And by EPS, obviously nerve conduction EMG. And those are, the reasons are obvious, right? You're damaging the nerve and you're going to require some nerve function to evaluate these, whether it's on EMG or nerve conduction. So it's a pretty complex picture. Imaging can help decipher some of these patients. And then in terms of whether you decide to treat these patients conservatively or surgically, we need to be able to follow up their outcomes. And again, imaging plays a huge role in this to determine, is the treatment working? Is the nerve regenerating? Or do we need to change course? So what do we use imaging for traumatic nerve lesions or injuries? So initially, at the time of injury, we determine the location, the type, and the extent of injury. We locate to see if there are concomitant injuries. We'll talk about double crush and multi-crush phenomenon. We'll talk about the surrounding soft tissues around these injuries and how important it is to evaluate for that, and the concept of nerve gliding. Sometimes you'll have foreign bodies. You'll have bony fragments, metallic surgical hardware that can interfere with these nerves, and I'll show you examples of those. So after the initial injury, after we have located the lesion, the extent of the lesion, the type of the lesion, et cetera, in terms of follow-up, we want to monitor the evolution of the injury. Is the nerve regenerating? How are the surrounding soft tissues doing? Do you have restoration of nerve lighting and normal vascularity? And then are we, in the case of motor peripheral nerves, is the end organ, skeletal muscle, coming back? Is it getting worse, or is it getting back at the innervation of fatty acid? If the patients are to undergo a surgical procedure, we can use imaging to help guide and shorten, hopefully, the OR times. We do that by marking the skin where the lesions are located. We sometimes place wires, and I'll show you examples of that, particularly in cases where the lesions are either too small or there's extensive soft tissue scarring around it. Intraoperatively, sometimes once the nerve is exposed, we can do intraoperative ultrasound to look to see the extent of the injury. Sometimes it's difficult on just preoperative imaging to determine, are we dealing with a grade 4 lesion or grade 3? Sometimes intraoperative ultrasound can help, and I'll show you some examples of that. And then postoperatively, yeah, we're going to monitor healing and potential complications. So let's start with the relevant peripheral anatomy. And again, for my senior colleagues, I apologize. This is going to be review. I think it's important for those students in the audience to kind of understand it. I'm going to put a spin on it specifically on imaging. So this is your peripheral nerve. You have the outer epineurium. It has collagen, so it's an outer sheet. Interestingly, around the epineurium, you have usually fat. So when I'll show you examples of MR and ultrasound, what I'm going to be calling, or what traditionally has been called as the epineurium, it's truly not. There is a layer outside of that, which is really the epineurial fat, which when we're doing these regional nerve blocks, or if I'm doing a hydrodissection, obviously I'm not looking to pierce through the epineurium. I'm trying to place the needle outside of the epineurium to distend away the surrounding epineurial fat. So in all of my needle procedures, unless I'm trying to biopsy a nerve or drain a cyst in a nerve, all of the hydrodissections or lidocaine steroid injections, et cetera, everything is meant outside of the nerve. And some significant complications can occur if we pierce the epineurium with the needle and inject, and I'll show you examples of that later. So again, this is the epineurium. Within the epineurium, you're going to have this fibrofatty connective tissues, and there are going to be blood vessels there. And this is very interesting because those blood vessels, as you can see on my little diagram and also on this pathology slide, those vessels are pretty big. And later we'll talk about the size of gadolinium contrast agents, gadolinium-based contrast agents. And one of the issues with gadolinium contrast agents is that when you inject an IV trying to get to the nerve, the size of the molecule will not be able to normally enter into the fascicle because you have a blood-nerve barrier. We'll talk a lot about the blood-nerve barrier, but it is normal, especially if you do high-res imaging, to see a little bit of enhancement in the vessels within the epineurium, but outside of the perineurium, okay? So, and this is what I'm referencing, and I'll show you examples of that in a second. So those are the normal blood vessels. When the nerves are injured, you're going to get leakage, predominantly from the fascicle. Those tight junctions within the endoneurium and the perineurium at the blood barrier, they're going to start leaking. And so contrast, larger molecules can now penetrate in. So usually the presence of enhancement, particularly within the fascicle, it's a stain. It denotes structural damage, whether through demyelination or true axonal damage into the nerve. And so enhancement is bad, but the presence or visualization of those vessels within the perineurium, outside of the endoneurium, outside of the fascicle, is normal. So there it is. There is your fascicle. We'll talk a lot about fascicular enlargement and the different appearances of that. But the fascicle is a nerve of group fibers. Well, you have the outer perineurium, and then you have your axons, myelinated and unmyelinated, and the milieu, the connective tissue that envelops that is the endoneurium. There is a complex capillary network there. Contrast should not make its way there. So you should not have enhancement at this level. And again, you also have other supportive cells to help maintain the peripheral nerve. So that's basically the layout. Here's that microcirculation and that concept of the blood-nerve barrier. Again, it's that combination of the tight junctions in the endoneurium, the endoneural space, and then the perineurium. And the truth, the concept is that it should be really relatively well preserved. This idea that you'll have transport through these axons in this normal pathway, in this preserved pathway where there's no structural damage. We're going to use that extensively when we talk about advanced MR imaging with DTI, something called diffuse retention imaging. We rely on that structural pathway where molecules of water can flow, and we can image that. So keep that in your mind. So two concepts to think about: permeability and the relationship with vascularity, and also structural flow of water, and it plays a role into imaging. All right, so what do normal peripheral nerves look like under ultrasound and MRI? So here is an ultrasound. This is a short axis view of a peripheral nerve. We talk about the honeycomb pattern. There's a couple of things you need to be aware of. Number one, not all peripheral nerves look the same because the fascicular anatomy is different. So if you look at the shape and number of the fascicles of an ulnar nerve versus a median nerve, they're different. They have different number of fascicles, different sizes. That has significant implications when we talk about nerve reconstructions with grafts. Ideally, you want to pick a graft that most closely resembles the anatomy of the fascicles. We can do that. When we look at the normal fascicular anatomy, or when the nerve is becoming distorted, we'll measure something called a fascicular ratio that I'll show you. You have to have an understanding of what a normal ulnar nerve looks like and compare that to what a normal median nerve looks like, because they look different. The fascicles are different shapes and different numbers. But regardless of what nerve you're looking at, what you do want to see is all of the fascicles being of the same size. So you should not have differences in fascicular size. If one fascicle starts getting enlarged compared to another, that's usually an indication of some intrinsic structural abnormality. That's going to be one of the main differentiating points between a grade 2 and a grade 3 lesion. And we'll go over that in a second. So if you look at the outer rind of the peripheral nerve, that's the perineural fat that I was discussing. Again, if I'm doing an injection, a regional nerve block, etc., I'm placing the needle outside of the epineurium and I'm injecting around it. So that echogenic bright area around the nerve, that's truly not the epineurium alone. That's really the epineurium with some epineural fat. All of the nerves have a certain degree of epineural fat. It's essential to have that normal connective tissue so the nerve can glide. I'll show you some dynamic ultrasound in a second, and you'll be amazed how much these nerves glide, particularly in the extremities. When you're moving your extremities around, you need that free motion. It's important for structural integrity. And also, if there is scarring of that epineural space, it's going to restrict blood flow. It's going to affect that normal vascularity that I was describing. So I'll get into that. So that's the outer rind. You also have fibrofatty tissue within it. So these bright areas between these round fascicles, that is in that outside of the perineurium. That's where those blood vessels reside. And again, you have fat there, and fat under ultrasound is bright. So that explains why you're seeing this. So if you know what normal looks like on ultrasound, you're going to start appreciating what abnormal looks like in a few slides. In terms of MRI, the same concept, you're looking at the same things, except that now you have to understand T1, T2, fat set, what am I seeing? So here it is, here's the nerve. So here is the nerve under high resolution ultrasound, as I've explained it to you. Again, that rind of echogenic material, which is that fat, what I call epineurial fat. And then you also have fat within it, between the fascicles. This is normal. All of the fascicles are pretty easily visible. I don't see any discrepancy within the size of the fascicles, or there's a good number of fascicles, so this is normal. T1 weighted images on MRI, great at looking at the fat around the nerve, but the problem is that there is some water in that endoneural space that gives you a little bit of bright signal on fat sat. Water is dark on T1. So if you rely only on T1 weighted images, you're not going to be able to see inside the nerve. You're trying to see inside the nerve to look at the fascicular architecture. We're going to talk about intraneural scarring and asymmetry. So don't use T1 to look inside the nerve. You want to use T1 to look at the fat around it. What you want to look on MRI to look inside the nerve is proton density. And you can do proton density with or without fat suppression. So if you look at this image, this is a perfectly normal nerve. Not only all the fat planes around it preserved, but if you look inside, it's a little bit brighter than the surrounding skeletal muscle. Why? Few reasons. Number one, there is water in the endoneural space. That connective tissue has some water in it. So it's going to pick it up and it's going to give that little bright signal. And then you're going to have the vessels that I described outside of the fascicles. And you can also see, and those are going to become even more accentuated if I give contrast. Not the signal in the fascicle, just the vessels outside. So that's what this normally looks like. If I'm evaluating this, I'll note that the fascicles are of the same size, same signal intensity, okay? And you've maintained that fascicular ratio, so an adequate number of fascicles to that connective tissue. So this is perfectly normal. All right, on long axis, I want to see that linear structural pattern. So whether it's MR or ultrasound, it doesn't matter. I want to see straight lines. I want to see those fascicles in continuity. And between the fascicles, I want to see that healthy connective tissue. So there is that fascicular honeycomb pattern. Please understand that, again, these are proton density or sometimes T2 weighted sequences. You're not going to see this on T1 because the whatever little water there is in there is going to give you dark signal. You're not going to be able to see it. You want to make sure that the nerve has a smooth contour, that it's traveling its normal path, that there's no obstruction, and the nerve itself should follow a nice taper down. You shouldn't have enlargement distally for obvious reasons. So here it is, axial proton density of the wrist, again, showing you an intact median nerve at the level of the carpal tunnel. And again, here is a fluid-sensitive fat site, either T2 or proton density. And the little bright spot there, that's the little vessels that I was describing to you. That's what I'm showing you, the little vessels outside of the fascicles. That is perfectly normal. Okay, so there it is, short axis, long axis on ultrasound, perfectly. All right, so now let's look at subtle abnormalities. Here's a different patient. This is a very symptomatic carpal tunnel patient. So when you look at this MRI initially, you may say, well, I don't see compression of the nerve. I know to look for flattening of the nerve of the carpal tunnel. This person is very symptomatic. How can I explain this? Is that little enlarged fascicles? If you pay attention, you'll note that that one fascicle is larger than the surrounding fascicles. This is significant, particularly if this patient has concomitant cervical spine disease because of that double crush. Now, I know there's some controversy regarding double and multi-crush, but it is something that I do see in my practice. I think that it does sensitize peripheral nerves. And this is an imaging findings that would be significant for this person that actually has symptomatic carpal tunnel syndrome, and it can easily be overlooked. So this is fascicular enlargement, asymmetric fascicular enlargement. So here's normal on the left. This is abnormal on the right. That one fascicle is enlarged. The fascicle is enlarged, and if you pay even closer attention, that one fascicle is hyperintense compared to the surrounding tissues. What that's telling you is that that intricate capillary network inside the endoneurium, within the endoneurium, is leaking. Fluid is leaking out, and it's giving you that high signal. So this is very significant. The next step would be if I gave contrast and that one little fascicle enhanced, that is also an indication that you have increased permeability. You're starting to get damage. I'm not able to tell you if it's structural damage, that the axons are getting injured, or whether or not you have demyelination, like an inflammatory process. Usually these inflammatory process tends to be more diffuse, not so focal. When I see these little focal abnormalities, they tend to be more of a compressive etiology that somehow, or for whatever reason, affected that one fascicle in and of itself. And eventually that may lead to intraneural fibrosis, that I'll show you. But this is the concept of fascicular asymmetry, very subtle, but very significant in patients. Here's a different example, okay? This one, normal on the left, abnormal on the right. This is fat side fluid sensitive. In this case, it's not the endoneurium that's abnormal. This is a combination of endoneurium and perineurial abnormalities. So the entire nerve is inflamed. If I look here, it's all edematous. There's T2 hyperintensity diffusely through the nerve. This is nerve edema. This is neuritis. The fascicles are not enlarged. That gives you some hints that the problem perhaps did not begin within the fascicle itself, but it's a more systemic issue throughout the nerve. But regardless, this is neuritis. This is a diffuse edema within the nerve without appreciable structural abnormalities on MRI. So it's not focal, it's diffuse. This is what I would call neuritis. You have to be careful. That was my voice, sorry about that. In terms of the one thing I'll draw your attention is to this, which is magic angle phenomenon. The concern here is that when you have a highly structured part of the body, whether it's a tendon, a ligament, or in this case, a nerve, if the nerve curves in relation to the static magnetic field, you're going to get artifactually increased T2 signal. This is a drastic example of that. So as you can see, the median nerve in the wrist making that curve. As it's curving, it's giving you that high T2 signal. You have to be careful. This occurs in proton density images. It does not occur in pure T2 or obviously T1. So that's one of the caveats of proton density imaging, and that's the so-called magic angle artifact. How do I know that this is artifactual? I look at the other planes. You have to evaluate it on multiple planes. If I see that it's confined to the area where the nerve is curving, if I see that the perineural fat planes are preserved and the fascicles are normal, then I know this is artifact. Just be aware of magic angle. The same problems arise in ultrasound. So what we call magic angle on MRI, we call anisotropy on ultrasound. So what does anisotropy mean? What anisotropy is if I have a highly organized structure and I insonate perfectly to that structure at 90 degrees, those ultrasound beams from the transducer will hit the structure and bounce back and give you a true representation of the status of that structure. However, if I tilt the transducer to that structure, the ultrasound beams will hit it and then reflect away from the transducer. The transducer will not receive the signal. The structure will appear hypoechoic. Low signal on ultrasound is equatable to fluid. Fluid usually means inflammation and pathology, but this is artifactual. This is anisotropy. We routinely see this on nerves. You have to be careful. This is why I scan all of the peripheral nerves myself. I have great techs working with me at Lennar. I trust them, but regardless, I like to scan myself. Here's an example of how it affects a nerve. So here's a long axis view of a nerve. You're insonating it correctly. And remember, you have to insonate not to the patient, but to the individual structure within the patient. So you constantly have to be altering the position of the transducer to make sure that you're insonating the structure appropriately. So this is the normal nerve, as you would expect, nice linear fibular architecture. But if I insonate at an angle away from the nerve or as the nerve curves, it's going to become hypoechoic. This is purely artifactual. You have to be careful of this. The other really important teaching point is, again, the surrounding fat planes. You have to evaluate the environment by where that nerve is situated. You have to look at the contour of the nerve, the shape of the nerve, where it's traveling, if it's taking an aberrant course or not, and then the surrounding soft tissues. So let me show you some examples of perineural and intraneural scarring. So here's the normal nerve on short axis, okay, proton density. Again, normal fat around it and normal fat within it. That's what you want to see. Here's a markedly abnormal nerve. When you see them side to side, you can really start appreciating the degree of architectural distortion. So if you look at this particular case, there's extensive perineural scarring. Okay, the nerve is actually being tethered to the skin and to the surrounding muscles. So that nerve can't glide. That nerve cannot appropriately regenerate. The blood flow is going to be compromised. And then even worse, if you take it a step further, it's not only perineural scarring, you have intraneural scarring. Instead of seeing the normal fat between the fascicles, I'm seeing scar tissue within the fascicles and between the fascicles. We know that normal nerves also glide between fascicles. So when you move your peripheral nerves, not only do they glide in relation to the surrounding soft tissues, they glide with relation to the individual fascicles. That's called interfascicular gliding. And I'll show you in ultrasound what that looks like in a second. But when you see something like this, this is markedly abnormal. This has no real shot of healing on its own. There's too much structural damage there. Okay, now let's take it a step further. This concept of nerve transport. We're all familiar with axonal migration. We know that motor nerves tend to have more proximal to distal migration, sensory more distal to proximal, and then obviously you have mixed nerves. We can use that to our advantage for in several ways. So one is if you're traveling down a path and you're obstructing it, let's say a motor nerve, you're going to get abnormal signal both proximally and distally, whether it's edema signal and also enlargement of the nerve. But it makes sense that the accumulation of product is going to happen along the direction of the path. So what I mean by that is if you have a motor signal where most of the signal is traveling distally, those motor nerves that are injured or focally transrupted are going to have signal abnormality predominantly proximal. Classic example of what we see there is your median nerve. Median, obviously, it's both, but median nerve in the setting of carpal tunnel, you tend to see more pre-stenotic dilatation and T2 hyperintensity, and that has to do with axonal migration. This path of axonal directionality is also important because if we're going to be using nerve grafts, ideally you're going to flip them. So if you use a sensory nerve graft for a motor nerve reconstruction, you want to flip the nerve so that you have the reconstruction along the anatomic path. This is also going to play a role in diffusion tensor imaging. So let's take a couple of examples. This is a patient with MRI of the elbow. If you look at the elbow, the ulnar nerve at the level of the cubital tunnel, you'll note a couple of things. There is narrowing of the nerve at the level of the cubital tunnel. It's thickening around it. That's perineural scarring. That is significant. And then proximal to that, the nerve is dilated, more dilated and hyperintense than distally. That's classic ulnar neuropathy. We see this a lot at the cubital tunnel, and that is explained by that axonal pathway. These little subtle changes become even more accentuated, again, in a double or a multi-crush phenomenon. So this one, you have to take everything into consideration. This is an abnormal ulnar nerve. And again, that discrepancy in the proximal versus distal differences in imaging is explained by this. And here's another example. I often get asked, well, how do you diagnose carpal tunnel on ultrasound? And you look at the papers and they're talking about a circumference of the nerve being enlarged. You have to understand that you have to measure the nerve where it's getting enlarged, and it's not going to get enlarged at the site of compression. So this is the classic carpal tunnel where the transverse carpal ligament in combination with the flexor tendons are narrowing the median nerve at the level of the carpal tunnel. Okay, so there it is, it's narrowed, but you're not going to measure the nerve size here. You're going to measure it before. So this is the long axis view of this patient. You can see the area of entrapment at the carpal tunnel, but where you're going to get those measurements that you read about in looking at overall size of the median nerve for carpal tunnel, it's prestenotic dilatation. You're going to measure it there. And so I get upset with my techs when they measure the cross-sectional diameter here and they say, well, there's no carpal tunnel, the size is not enlarged, but you're not understanding it. You're not going to measure where it's getting compressed, you're going to measure it proximal. Notice how nicely, not only does the ultrasound tell you about stenosis and prestenotic dilatation, but also fascicular congruity. Look how the lines of the fascicles are maintained under ultrasound. You can use that in both a preoperative and a postoperative setting for nerve regeneration. And I'll show you that. I just wanted to train your eye to look at that fascicular continuity, even in the setting of compression. Compression can be caused by other things. We can nicely see that. So things that cause artifact on MRI, like metal, easily seen on ultrasound. This is a surgical screw compressing a nerve. I just wanted to show you this. If you're ever in a case where you're getting a lot of metal, resort back to ultrasound. We can see the nerves really nicely, and the metal does not affect this. Here's that concept of double or multi-crush. I think this is a real thing. I see it in my practice. I know it's controversial, but the idea is that nerve function is going to be impaired in a single axon if it's compressed in more than one region. That kind of makes sense with this concept of axonal transport. It also helps me understand why subtle abnormalities in the ulnar nerve, like if my ulnar nerve looks like this, but I'm not symptomatic, maybe I don't have as much cervical myelopathy. But if I have a patient that either has cervical or concomitant brachial plexopathy, and then they present with ulnar nerve symptoms, it helps me understand that even though this little nerve is a little bit abnormal, it is still clinically significant. So just that concept of blocking that road at multiple levels. And then lastly, the last concept to keep in mind regarding this axonal transport is diffuser tension imaging. You'll hear a lot about that. You read about the promise of DTI. It is helpful, but it's not as helpful as you think. Let me show you what I mean by that. So the idea here is that water molecules that are in a free environment, they're able to move around and diffuse through membranes freely. And that's called isotropic movement. That's all it is, okay? So it can move equally in all directions. The moment you take those water molecules and you place them in an organized state, in this case, along an organized mature nerve where the axons and that architectural anatomy that I showed you is in place, that will restrict the motion. We're going to call that anisotropic motion of the water molecules in a normal state. And that's going to give you high signal on DTI. That's basically what it is. Actually, it takes it a little bit further. The water molecules will actually change shape. So if the water molecule is relaxed in a non-restrictive environment, it'll be nice and round. If you place it in a highly structured environment, it's going to appear ellipsoid. It actually changes the shape of the molecule. But again, using these differences in shapes and direction, using diffusion tensor imaging, we can determine the magnitude, the degree of this anisotropy, and the orientation of direction. And when we do that, there's different ways that we can apply this technology. But again, the idea is that if you have free motion, it's going to be lower signal. If you have organized motion, meaning structural integrity, you're going to have higher signal, okay? So anisotropy means higher signal. And you can measure it in different ways. The most reliably for peripheral nerves is using something called fractional anisotropy. It's a ratio. I don't want to confuse the audience, but the simplest way I can tell you is that for fractional anisotropy, you're doing a ratio, so it's always in comparison to something else. And the idea is that if you have a fractional anisotropy value of 0, it's a perfect sphere. The water is freely diffusible. The structure is damaged. If you have it closer to 1, it's a highly organized linear structure. The water molecule is more ellipsoid. And the reality is that in human tissue, you really never get to 1, especially in peripheral nerves. The closest you're going to get is 2.9. So how can we use that? Well, damaged tissue is not going to have high signal on DTI when you apply fractional anisotropy. So here's an example of a healthy individual and an injured individual. This is from a research study looking at ulnar neuropathies. And all that you're doing is comparing the abnormal ulnar nerve where there's a lower diffusion coefficient, so lower fractional anisotropy, so lower signal in comparison to the healthy side. That's it. We represent this on a color map. Again, it indicates that the nerve is injured. We can use that in the postoperative setting or in the recuperative setting to see if the nerve is regenerating, but understand that this is very sensitive. So if you have metal or if the patient moves, it's very prone to artifact. I think it's helpful, particularly for research purposes. For clinical day-to-day operations, this is very cumbersome. So even though it's exciting technology, it is not as helpful because of the limitations that I've told you for your routine patients. And we can get pretty fancy with this. We can generate beautiful rendered images where you have what's called fiber tracking or tractography. All you're doing is taking those values that I showed you, the brightness scale, and applying it in a beautiful little map. And then this is just visually representing that prolongation reduction in signal intensity with lower fractional anisotropy to indicate the site of ulnar nerve injury. It's nice, but please, the standard MR sequences and ultrasound will provide you a lot more useful information than this, in my opinion. All right, going back to the blood nerve barrier, again, endoneurium, perineural layer, tight junctions does not allow migration of larger molecules like your regular IV contrast. So IV contrast is not going to go there. If you have a nerve damage, either due to Wallerian degeneration, inflammatory disorders, demyelination, crush, etc., you're going to get disruption of this tight intercellular junctions, and it's going to increase permeability of the nerve. So these nerve contrast agents, we don't have a dedicated nerve contrast agent just for peripheral nerves. They will come online. There is research being done on this, whether it's going to be based on imaging or tying in a radiopharmaceutical or optically being able to see this. There's a lot of exciting things being done looking at external transport. All of this is still in the experimental phase. None of them have applied to clinical practice. And obviously, all of them have a lot of limitations. But I just want to introduce the concept of this regular IV contrast. When you order an IV contrast MRI, what am I looking at in a clinical setting? And the idea here is that your regular gadolinium, whether it's DTPA, DOTA, or DO3A, none of them are small enough to get into the endoneurium. So if you see enhancement, it's abnormal. So what is considered normal enhancement? I showed you this earlier. This is an axial image of a sciatic nerve, pre-contrast, post-contrast. It is normal to see those vessels outside of the fascicle. Those were the main vessels that I was telling you about. And again, if you do high-res MR or if you do ultrasound with very good Doppler imaging, you'll be able to see this. So this is normal vessel enhancement. That's not abnormal. That's what you want to see. What don't you want to see? You don't want to see leakage. So if this is normal enhancement, this is markedly abnormal enhancement. Notice that you're getting all of the fascicles enhancing and some of the contrast is leaking beyond the fascicle and into the perineurium. So this is staining, what I call staining of the nerve. The contrast is flowing into the nerve where it shouldn't. If this becomes mass-like, then you worry about a tumor. In this case, this is just diffuse leakage, so a lot of injury, structural damage to the nerve. Those tight junctions are affected, okay? So this is normal enhancement, abnormal enhancement. Now you see what I'm looking at. And obviously, when it becomes mass-like like this, obviously you have a tumor. But you can get mass-like enhancement of nerves even in the setting of non-neoplastic conditions. So you can get mass-like inflammation or neuromas forming, which are not neoplastic, they're just scar tissue that can enhance as well. We use other things. I don't want to make the lecture about tumor imaging. I can do one of those, a peripheral nerve tumor imaging. I just want to keep it separate and just deal with traumatic injuries. But I just wanted to show you how, because I get asked, well, how do you pick up a tumor? It's you look for mass-like and massive architectural distortion, right? So this happens to be a schwannoma, bunch of signs, the tail sign, the split fat sign, etc. But this is tumor. We're going to move away from it. All right. So now in the last part of the lecture, let's get into the injuries. Let me show you, now that you have the basics, how do I use the basics to further characterize these injuries, right? Using the Seaton and Sutherland, what's going through my mind. So let's start with it. So historically, 1943, you're all familiar, Sir Herbert Seaton broke it down into neuropraxia, axonotmesis, and neurodemesis. Back then, great, very helpful back then, not so helpful now for what I do. Why? There's a lot of overlap. Okay, I'm not reliably able to call everything either axonotmesis or neurotmesis because there's going to be multiple different grades. As you have more connective tissue injury, your grading starts to stratify out. But initially, this was very helpful. Okay, and again, the classic teaching is for your electrophysiological study, your nerve conductions, EMG, that in neuropraxia, they're going to be normal. In axonotmesis, there's going to be reduced. And in neurotmesis, there's going to be loss of conduction. But again, there's a lot of overlap. There's a lot of overlap in the two. So the classification is very limited in that sense. Now, 1951 Sutherland, this concept of what I call inside-out injury model, which is not perfect either, but it's somewhat helpful. So grade 1 and 2s would correspond to Seaton's neuropraxia and axonotmesis respectively. Now, when you get into actual structural damage of the connective tissues, you're dealing with grade 3, 4, and 5. Again, more damage to the endoneurium, perineurium, and then eventually the epineurium, and I'll show you that on imaging. The literature can be confusing. There is ambiguity when you talk about a Sutherland grade 3 or 4, and if old literature will consider a grade 3 to be axonotmesis, newer literature considers to be correctly grade 3s to be neurotmesis. I would move away from those terms. I would just stick to grade 1, 2, 3, 4, and now there's actually a grade 6. This lastly described grade 6. It's fighting that inside-out theory. This is by McKinnon and Dillon. The idea in a grade 6 is that you're dealing with a mixed type injury where you have involvement of various layers across a cross-section, not necessarily from inside out. That's where the grade 6 comes in. But regardless, let me stick to the first grade 5. This is just to show you, again, that change in terminology. So again, axonotmesis, we used to consider this type 2 to type 4, and then neurotmesis to be type 5. This is wrong. This is more in line to what we're seeing. So neuropraxia, stick to grade 1, that's fine. Axonotmesis should really be confined to grade 2, and then neurotmesis, anything 3 or above. But again, stay away from this classification. All right, so what are the findings? What information am I going to extrapolate from imaging to help me decide if this is a grade 1 or a grade 5? All right, so I'm going to look for nerve edema. Nerve edema means T2 hyperintensity on MRI or hypoechoic ectotexture on ultrasound. Nerve enlargement. So one is the nervus edematous, like I showed you. The other one is the nerve is starting to get bulky. Okay, and then I look at, for motor nerves, I'm looking at end organ damage. So the differences between a grade 1, which just shows edema, and a grade 2, where the nerve is now edematous and enlarged, over time in the grade 2, you're going to see some denervation changes to skeletal muscle. You should not see that with a Saturday night palsy at grade 1. You're not. With a grade 2, with a true axonotmesis, you may over time. But regardless, those two, they're pretty benign. They will recover. They should do well. Fascicular enlargement. I showed you an example of a fascicle being disproportionately enlarged. That's very important. Why? Because it helps me distinguish between a grade 2 and a grade 3. Once I see that fascicular enlargement, by definition, that's a grade 3 lesion. Grade 3 lesions imply that there's structural damage. The nerve is going to take a longer time to regenerate and may not even regenerate completely. And because there's more structural damage, you're going to see fibrosis, either within the nerve, in the fascicle, or around the nerve, depending on the type of injury you're dealing with. The grade 4s is the realm of interruption. Anytime I see those fascicles, not enlarged, but now there's interruption, I cannot see those axons in continuity on those long axis images, I'm dealing with a grade 4 injury. There's grade variations, whether it's a partial or complete. The idea here is that the epineurium is intact. You're going to see end organ damage in the setting of skeletal muscle. And in this example is over time where you're going to develop those neuromas in continuity. So if I see a neuroma in continuity in a nerve, that helps me. That's a grade 4. Those neuromas take time. So in the acute setting, I'm not going to see them. I have to rely on fascicular disruption, not only enlargement. And then lastly, the type 5s, you have epineurial discontinuity. That can be challenging because sometimes you don't have a clear nerve gap. And sometimes the scarring, the epineurial scarring, makes you think that there's an epineurium, but there isn't. It's just scarring of that outer connective tissue. And you're going to get the bulb neuroma. So let me show you on imaging. Again, grade 1, it's hyperintense. Grade 2, it's hyperintense and enlarged. You may see skeletal muscle denervation. Grade 3, the fascicles are now big. Grade 4, the fascicles are discontinuous. And grade 5, the epineurium is discontinuous. Over time, you're going to develop the neuroma. So here it is. Here's your grade 1. All right, so this is, in this case, this is a radial nerve. The nerve is hyperintense on MRI. You don't see one fascicle being larger than the other. The nerve itself is not enlarged. It's just T2 hyperintense. Most of the cases of clinical neuropraxia, the nerve is normal. The nerve will appear normal by the time of imaging. These will obviously do well on their own. And again, no skeletal muscle denervation. You should not see that. You should not see enlargement, fascicular disruption, or skeletal muscle. This is a grade 1. Here's another example of neuropraxia. Again, the entire nerve is hyperintense. One fascicle is not bigger than the other. We're good. Okay, grade 2. What's the difference between a grade 1 and a grade 2? Two things. One, not only is the nerve hyperintense, but now the nerve is going to be enlarged. So the nerve is big, not that the fascicle is enlarged, just the whole nerve becomes enlarged. So if you look at the ultrasound here, remember fluid on ultrasound is dark. So the nerve is hypoechoic, it's enlarged. Okay, so that's classic grade 2. I don't have fascicular discontinuity. One fascicle is not larger than the other. Obviously, I don't have extensive perineural scarring or neuroma formation. And then distally, I have denervation changes in skeletal muscle. There we go, grade 2. Here's another example of a grade 2. This is the ulnar nerve. It's bulky, it's hyperintense, but I can follow the fascicles, no neuroma, no end organ damage. That's grade 2. All right, grade 3. Anytime you see fascicular enlargement, now that you know what a normal nerve looks like, look at this. There is perineural scarring. There is intraneural scarring. The fascicular ratio is markedly abnormal. You have 4 fascicles when you should have 20. Okay, the other fascicles are getting squeezed. This is structural abnormality. This is grade 3. So when you see this disproportionality of intra and perineural scarring with fascicular distortion, that fascicles are enlarged, not disrupted, but just enlarged, this is the pattern of grade 3. And again, grade 3 tends to be more accompanied with this concept of scarring in the longer term. And yes, you're going to have end organ damage. You're going to see denervation changes distally. That's how I distinguish grade 1, 2, and 3 on imaging. Relatively simple. Okay. Here's another example. They often come in combos. You can't just think binarily. You have to kind of open your mind. So this is a soccer player, got injured, developed a foot drop. If you look, here's the tibial division of the sciatic nerve. Here's the peroneal division. There is differences between them. In this example, the nerve is hyperintense and enlarged the tibial. So this would be a grade 2. In this example, in the peroneal nerve, not only is the nerve enlarged and hyperintense, you have disruption of the fascicular ratio. One fascicle becomes enlarged compared to the other. This is grade 3. So these are differences. So you're seeing both grade 2 and grade 3 changes. And those are seen on the MRI, but they're better seen on the ultrasound. So there it is, large nerve, edematous. This one, the fascicle number gets off. This is grade 3, okay? But if I look at it in long axis, I'm still able to follow the axon, so I'm not gonna get discontinuity. You have to be aware that one of these fascicles can dominate. This has been described in the literature. So instead of having the normal fascicular ratio, here's a dramatic example. Sometimes you scan them and you see one huge fascicle. This is grade 3. It's just that you have one dominant fascicle becoming enlarged, compressing all the other fascicles. Very clinically significant. But this is the end result of that. So don't be fooled by that. It's not a mass or a cyst. It's just one very dominant. And again, if you look at it in long axis, it'll help you. This is one of very helpful paper came out in 2017, looking at normal variations in fascicular anatomy between different nerves and their ratios. And then they followed it as the nerves became inflamed. So this is ulnar nerve, median nerve, peroneal nerve. Notice that the shapes of the fascicles and the normal and the number of the fascicles, there's variations. You have to be familiar with that. And then as the fascicles become inflamed, as you're transitioning between grade 1, grade 2, and grade 3, you're going to get those inflamed fascicles become enlarged and crouch the others. So your fascicular ratio goes down. So it starts higher and then mild, moderate, and then severe. Look at the distortion, okay? So this is severe inflammation of the nerve comparison to the normal. Again, to delineate to you the differences in the morphology of the fascicles and their numbers and as they change with inflammation. Again, this can be helpful when you're trying to assess for adequate grasp for reconstructing individual nerves. If you want to take it a step further, this concept of fascicular ratio, this is a pilot study looking at fascicular ratio as an estimation of assessing regeneration following nerve grafting. This is from China, different patients, different nerves. It doesn't matter. It's just more the concept that I want you to understand. So this is the normal fascicular architecture, normal fascicular ratio, and these are patients preoperatively and postoperatively. If you note, preoperatively, there's a markedly abnormal fascicular ratio. The honeycomb pattern is disrupted. If you have restoration of the fascicular pattern, with restoration of the normal fascicular ratio, that's an indication of nerve regeneration. So that's one of the things that I use when assessing these nerves postoperatively. It doesn't have to be postoperatively. If you're just treating these patients conservatively and you want to monitor their progression, I use the same fascicular ratio. I just wanted to show you what I'm talking about in terms of fascicular ratio. Okay, nerve gliding, really quickly. Extensive soft tissue injuries, again, normal fat around and within the nerves. I explained to you the differences between one and proton density and how we use that to see fat around and fat within. Okay, ultrasound, let me show you some significant architectural distortions. When I see these architectural distortions, they're going to be a grade 3 or above injury. So here's the normal nerve. I spent quite a bit of time going over the normal surrounding fat planes. These are markedly abnormal nerves under ultrasound. Not only is the architectural distortion, the fascicular architecture distorted internally, so there's intraneural scarring, but the surrounding soft tissues are markedly abnormal. Look at the distortion in tethering and scarring. Here it is on long axis. Again, I can still follow the nerve, but they're enlarged and the nerve is getting kinked on multiple areas. This is quite significant and very, very symptomatic. Here's another example. So normal on the top, abnormal on the bottom, extensive surrounding soft tissue scarring. This nerve has very little chance of healing. It compromises their gliding, it compromises their axonal transport and vascularity. So extensive soft tissue scarring around. And so the idea here is limb motion in nerves, they glide back and forth when you move your limbs. So interestingly, the plexus can glide up to 5 centimeters when you move your shoulder, abduction and adduction. In terms of your ulnar and median nerves above the level of the elbow, they can glide up to 8 centimeters. That's amazing. And then the median nerve at the carpal tunnel can go up to 10 centimeters. So anything that restricts the gliding becomes clinically significant. The other issue that you can assess on imaging is not only is the nerve being tethered by scar, but is it popping out of its normal location? This is the classic medial elbow snapping syndrome. The patient presents, you're wondering, is it the triceps or the ulnar nerve that's snapping out of place from the cubital tunnel? I do it under ultrasound. There is the ulnar nerve. It's markedly abnormal, and it's abnormal. It's getting upset, inflamed, because it's constantly dynamically flipping over that internal epicondyle. This I cannot see under MRI because it's not dynamic. I rely on ultrasound, and then this was reproduced in the OR, again, showing that medial elbow snapping syndrome, okay? So we use ultrasound to look for abnormal motion of the nerves. This is the normal gliding. So this is the normal median nerve at the level of the forearm. So this is muscle, there is the nerve. You can nicely see the fascicles. This is a long axis. You see the perineural fat around it. And notice that the nerve is not only gliding within itself, but in relation to the surrounding tissue. So the fascicles are moving, which I evaluate, and also the entire nerve unit is gliding with regard. This is very, very helpful. If you have loss of gliding, it can become very, very symptomatic, okay? So let me show you some examples. This was a 10-year-old female. She presented. She had difficulty gripping the pencil. This is at the level of the carpal tunnel. So right off the bat on the static images, you can see that the nerve is markedly enlarged. The fascicles are enlarged. So this is, you're dealing with a grade 2-3. So right off the bat, the fact that the surrounding scar tissue is so thickened and on long axis view, this would be a grade 3 injury. So I don't have fascicular interruption, but I have excessive perineural scarring. But she was so symptomatic. This was crazy. Here's the long axis view of the nerve. If you follow the median nerve is being kinked in itself by the scar tissue. So every time this little girl moved her wrist, it would bunch up the median nerve and compress it. And I'll show you that on dynamic images in a second. You can appreciate that on the sagittal MRI. This is not a tumor. This is not a neuroma. This is perineural scarring causing kinking of the nerve. If you were just to evaluate this nerve on the axial images, you would miss it. But here it is on the dynamic ultrasound. I showed you normal. Look how abnormal that nerve is. When she tries to move her wrist, the nerve is bunching up in and of itself. So again, you cannot solely rely on static images. You have to think of motion and how all of this scarring plays a role and restricts normal gliding. If we take this a step further, when we have even more trauma, whether it's a compartment syndrome, Volkmann's contracture, post-radiation changes, you're going to start now appreciating these cases that I'll show you and how drastic these changes are. Look at this. This is a patient with compartment syndrome. So you have multi-nerve abnormalities. Not only are the nerves hyperintense and enlarged, you obviously have fascicular disruption. You're dealing with at least a grade 3, but then look at the soft tissues around it. They're all scarred and disrupted. This is a massive problem. Obviously not healthy tissue to operate in. long segments of perineural fibrosis, big problem. This is compartment syndrome. Here's another example of compartment syndrome. Again, multi-nerve distribution, extensive surrounding muscle and soft tissue injury. So classic compartment syndrome. Classic, the same concept can apply for a multitude of other problems. Here's Volkmann's contracture. Again, the same idea, multi-nerve distribution, marked abnormalities, marked soft tissue changes. And then lastly, this is a patient that developed post-operative tarsal tunnel syndrome. Look at the extent, when this was initially read, this was missed. But this is pretty dramatic. If you look, there's extensive perineural scarring. So the nerve is actually getting tethered on the MRI. And if you can imagine what that ultrasound looks like when they try to plantar flex and dorsiflex the foot, they won't be able to move. And so here it is pretty drastically. So the entire medial and lateral plantar nerve divisions of the tibial nerve are scar encased. And within it, you can get some neuromas as well. So just appreciate the surrounding. It becomes really, really important. All right, so grade 3, again, extensive perineural scarring, intraneural scarring, but you shouldn't see fascicular disruption. Okay, you can get some art. This is challenging. This differentiating between grade 3 and an acute grade 4 is very, very challenging because sometimes that perineural scarring can make you believe that there's fascicular disruption. The key again is to identify fascicular disruption. I struggle with this a lot. I rely on the long axis ultrasound images, trying to see if those fascicles are in continuity. And these are just different examples of surgically proven grade 3s. Here's one recent one. Again, this patient had a fracture of the humerus. There was radial symptoms. There was scar encasement, a lot of perineural fibrosis, so definitely a grade 3. The question is it a grade 3 or grade 4? The nerve got tethered by where the fracture was. You can see it on the MRI. And here is the ultrasound. And in this case, the question was, I still think I can see the fascicles going through this. I don't think there's fascicular disruption, just scarring. So this was a grade 3. That's how I determined that. Again, teasing scarring from fascicular disruption. And this was the ultrasound of the patient. Again, on the ultrasound, I can see the lines. So it's definitely tethered. It's not moving. But if you pay close attention, you can follow those white lines within the area of scarring. So the fascicles remain intact. That's how I can tell. And then this was confirmed at surgery. So a lot of perineural scarring, researching gliding, but this was not a grade 4. This stayed in the grade 4. Okay, so let me show you quickly some grade 4s. Again, the key here is any fascicular interruption. So here is the fascicles are going, and then I don't see it. It's more than scarring. I actually have fascicular interruption, and they vary in degrees. So what can help me over time? Neuroma. So if I see a mass, a neuroma within the nerve, by definition, I know it's a grade 4. And obviously, you're going to have a lot more end organ damage, a lot more denervation changes. So these are the classic neuromas in continuity. So different examples of grade 4, both on ultrasound and MRI. But again, in the acute setting, I may not have the benefit of the neuroma, so I have to look for that fascicular disruption. Here's an example of a 52-year-old woman that had a laceration of the wrist. She was washing dishes. She cut her median nerve. Again, you're seeing interruption of the fascicles. This enlargement is not neuroma formation yet. It's just the edematous nerve. But it's the fact that I cannot see the fascicles going through. So this is a grade 4 injury. This is not grade 3. Here's an ultrasound of another patient with a grade 4. Again, as I'm following the nerve, you see the neuroma. You may even see cystic interruption. This is obviously a grade 4 injury. Some of the nerves still make it. Grade 5, those tend to be simpler. Again, you're going to get a gap in the ideal setting. You're going to get bulb neuromas at both ends. The denervation changes to the muscles are going to be a lot more pronounced. Don't be fooled by this hourglass waist. This is not the epineurium. This is just the scar tissue around the epineurium that makes you believe that you have epidural continuity. This is an obvious case of a grade 5, given the retraction and the separation between the torn ends, the ruptured ends, but sometimes the gap is not that obvious. And sometimes in small nerves, all you see is the neuroma. So this is a patient with a digital nerve. She had a laceration by the radial digital nerve of the small finger. As you see the nerves there, and then she presented with this mass. The mass is the neuroma. It's not a peripheral tissue tumor. She cut the nerves, formed a neuroma. The nerve is so small that you can't see the gap, but there's no normal nerve fibers going through this. So this, by definition, is a grade 5. It was proven surgically. Now, a quick word in terms of anatomic variance to nerves. I don't want to spend a lot of time. I'm running out of time on this, but you have to be aware of anatomic variance. One of the catastrophic consequences, for example, is this. This is a congenital bifid median nerve at the level of the carpal tunnel. They're often accompanied by a persistent median artery, which is what I'm showing you there. If you do not alert the surgeon ahead of time that this exists, and they go do a carpal tunnel release, they may tag one of the nerves, thinking that's the entire nerve, and then start cutting. So let me show you an example of a different patient that had this problem. So this is a patient that had a carpal tunnel release and had a congenital bifid median nerve. Unfortunately, the surgeon cut one of the limbs of the median nerve. Patient developed, this was a grade 5, developed a neuroma. This was very unfortunate, but it happened. So there is the neuroma in a grade 5 injury. We use ultrasound. This is something that our group has published. I don't want to dwell on this too much, but I want to go through this concept of the hourglass. So this is someone that had a laceration. The perineal division definitely has a transection with a gap. This is an obvious grade 5. The tibial division, though, appeared on the MRI as if there was something there. So the question is there something there or not? Am I dealing with a grade 4 or grade 5? So you do the ultrasound, and there is that hourglass. So nerve coming down, neuroma, nothing in the middle. This is not epineurium. That's just scar tissue. Okay, so it looks like a waist. So this is a more difficult case, but the ultrasound really helps you. This is a grade 5, and this was shown in the OR. Again, not a lot of normal epineurium. We use ultrasound to guide it when there's a lot of scar tissue, and I'm sorry I'm going a little bit quicker, but I want to get through some of these. Again, if you have a lot of perineural scarring and neuroma formation, to shorten OR times or to help you identify, we can guide these wires to help and identify these lesions. Also in larger, longer segmental peripheral nerve injuries, we can tag the ends of it to hopefully, again, make dissection a little bit easier. So this is neuromas of the infrapatellar branch of the saphenous nerve following ACER reconstruction. And so we can help with that. So we basically guide a wire around the area, wherever you need us to target, and leave it, and you can dissect down. Okay. In terms of, and this is that other case we published in terms of the long segmental defects. I'm sorry, I'm going through this a little bit quickly. All right, let me quickly end in the last couple of minutes on image-guided peripheral nerve interventions, and then a little bit on the postoperative appearance. So what can we do under ultrasound? We can do a lot of things. If you have a cyst that's compressing the nerve from the outside, we can drain it. Will the cyst recur? Most likely. But why are we doing it? To help you confirm the diagnosis. If you have a cyst either in the nerve or outside the nerve, and you drain it, and the patient gets better, you'll have a higher confidence that if you do an operative procedure, they'll be successful. So this is an example of an intraneural ganglion cyst within the tibial nerve. The fluid arises from articular nerve branches, classically in the proximal tibiofibular joint. Joint fluid will dissect along the nerve, and it can come all the way up from those articular branches up the perineal division of the sciatic. But this is what it looks like. The fluid can compress the normal fascicles, so they're going to get denervation changes. In this case, this is the popliteal muscle. So this patient was symptomatic. So in this case, I attempted to do, again, an ultrasound-guided decompression of those cysts. There were many of them. It will provide some short-term relief. The cysts will come back because I have not eradicated the neck. So these really should be treated surgically. But again, the point is to help you with your diagnostic confidence that indeed this will help if you go in there surgically and take care of it. For cysts outside of the nerve, this is the classic tarsal tunnel syndrome with a cyst. Again, can you deal with this operatively? Of course. Do you need to have every one of these drains? No. In those cases where you have a diabetic with spine issues, peripheral neuropathy, et cetera, and you really want to make sure that if you go in there and get rid of the cyst, it will cure them. First, drain the cysts under ultrasound and see if they get better. If they get better, then you know they'll do fine. And this is just me draining a cyst in the tarsal tunnel. And then lastly, hydrodissection. So in non-operative candidates, people that have a lot of perineural scarring, we do a hydrodissection. It's to break some of that scar tissue. Now, those cases of Volkmann's contracture compartment syndrome that I showed you, will they be ameliorated by this? No, it's too much. But if you have focal areas, yes, we can make them better. The idea, again, is put the needle away from the epineurium around the nerve and dissect out with saline. That's what I'm doing here. And so this is a carpal tunnel. Again, you're dissecting around the median nerve to create some space. This is not definitive treatment. This is not meant to be the treatment. It's just to help those non-operative candidates. You have to be careful when you put the needle. For my colleagues, I recently gave a grand rounds for anesthesia for pain management. You have to be careful. There's a lot of complications of putting needles into nerves. You need to know what you're doing. The basic concept is, again, when guiding a needle, do not violate the epineurial space. If you're going to do something with a needle in a nerve, don't pierce the nerve unless you're trying to biopsy the nerve or decompress a cyst, obviously. But if you're just doing some sort of nerve block, et cetera, steroid injection, you want to put the tip of the needle outside of the epineurium and inject around it, okay? If you make the mistake and put the needle into the nerve, don't inject, because by injecting, you're creating more damage. So please, if you're okay getting into it if you have to, but back out and don't inject. And then most definitely don't inject into the fascicle. That's the worst thing you can do. That's going to cause the most damage. It's going to cause mechanical damage, vascular damage. The nerves can hemorrhage, and then you're going to have the neurotoxicity from the stuff that you're injecting. So please, please, please be careful. In terms of intraoperative ultrasound, you can't, once the nerve is exposed, you can put the ultrasound on the nerve to determine the degree. Am I dealing with a grade 4 or grade 5? How much of the nerve is involved? Am I going to go in there and take the neuroma out and maybe try to do a primary repair, or do I have to sever the whole nerve? This is work we've done looking at this, or looking at the ultrasound. Now that you know what these neuromas look like, you can better assess. So again, in these cases, the MRI is really not that helpful. The intraoperative ultrasound is. You're confirming that there's really not a lot of fascicles left, and you really do need to do reconstruction. Okay. Lastly, and I'm sorry that I'm going through this a little bit quickly. Let me spend 2 minutes, and I know I'm a minute over time, but I want to spend 2 minutes on postoperative imaging. And maybe in the future date, I can just dedicate a grand rounds only to this, because there's a lot of information here. So what do we use imaging in the postoperative setting? We want to see nerve regeneration. Basically, that's what it is. I want to see restoration of nerve gliding. I want to see absence of perineural fibrosis. I need to understand what the operative procedure was. So in the setting of primary repair, the main thing to think about is a tension-free repair. How can I assess a tension-free repair? Dynamic gliding. I can assess for tension in your reconstruction dynamically under ultrasound. I can assess for scarring by ultrasound. That's why I showed you all of that. So again, the concept of tension-free repair, this is a primary repair that was done on a nerve, and this is what it looks like under ultrasound. So here's pre-op, the separations of the fascicles. Here's post-op, restoration of fascicular integrity. And then again, dynamically, if I were to move it, everything would move in conjunction freely and smoothly. I know there's no tension. This will do very well. Okay. Cable grafts, similar concept, a little bit different. There's no epineurium, right? So I know that the anatomy is going to be a little bit distorted. So in the cable graft, whether you're using autograft or allograft, it's kind of like the same. I have a concept of the fascicular anatomy. So I don't, I know that it's going to look a little bit different. And then this is the ideal scenario. This is something published by Dr. Levy. Again, this was a kid, very successful outcome of an ulnar fracture that had a traumatic injury to the ulnar nerve. This underwent cable graft reconstruction. But look at the postoperative. This is as good as it gets. You have complete integration of the graft with the native nerve, both proximal and distal anastomotic. These are the anastomotic sites. You want to see that linear continuity. You don't want to see interruption. And you most definitely do not want to see neuroma formation. The moment you start seeing neuroma, that will never heal. That scar ball will never go away on its own. Let me show you some examples of this. So here's a patient of another traumatic nerve injury. This is a recent patient. She's actually one of our nurses here at the hospital. She went outside of her institution for carpal tunnel release. They resected her median nerve. Unfortunately, here's the ultrasound with it's a grade 5 injury, and this is in the OR. You can see the gap. The patient underwent allograft reconstruction. In this case, they used an envelope to cover it. This is important. Whatever conduit or nerve, I have to account for that. I need to know that that exists because it's going to change the appearance. Let me show you her postoperative ultrasound. She's not doing well. So right off the bat, I have this rind of tissue around your reconstruction. That's that envelope. That's that sheet that they use. I need to know that that's there. So that's to be expected. And then if you look at actual anastomosis, part of the anastomosis has restoration of fascicular architecture. That part's doing well. But notice towards the left, there's a bulb. There's architectural distortion and neuroma. So I have to quantify. I have to say, look, this part of your reconstruction is not doing well. It formed a neuroma. And I can estimate the size, the location, and that will account for her lack of progression. Okay, and here it is on long axis. Again, mass-like distortion, no fascicular continuity throughout the graft. This is a partial failure. Here's another example. This one was of an ulnar nerve reconstruction, both motor and sensory. Patient was doing kind of well postoperatively and then regressed. So what happened? Here it is. If you look at the ulnar nerve, again, you see the mass. Architectural distortion with mass. Now it becomes easy. Now you know what to look for. This is neuroma. This will not do well. And not only that, more distally, where the little graft was placed, it becomes atrophic. So when you have a dominant neuroma, that part of the graft just disintegrates. It becomes atrophic and disappears. So you have to be mindful of whatever envelopes are being used, the concept of neuroma, and then atrophy of the graft. And then lastly, just using a conduit, this is from the literature, if you have a segment of non-critical length segmental defect, if for whatever reason the surgeon opts not to do a graft and just put a conduit, so the two nerve endings are there, they're sutured to the conduit. This is what it looks like. This is showing you the regeneration of the nerve through this conduit. Again, this is 1 month post-op. These are the anastomotic ends, and there's obviously nothing in the conduit, but over time you start seeing those train tracks coming, reforming, and the nerve is reconstituting. This is at 6 months. Again, this is from the literature. You can get a little bit of enlargement at the anastomotic site. That's okay. It's a little bit of scarring, but most of the conduit is regenerating with nerve tissue, again, from the literature, and there it is, distal anastomosis. And then lastly, the most exciting part is this TMR. We're routing nerves and amputees to help them with prosthesis and pain. We know that TMR can help with postoperative pain. And so the idea here is, in this case, this is an upper extremity amputation. You're going to route either the musculocutaneous, medial, radial, and ulnar nerves, mainly to the pec, both the clavicular head, and then you're further subdividing the sternal head into medial and lateral. And so the idea is to help them so that they can have a functional prosthesis. There's a lot of exciting work that's being done with these quote unquote bionic arms, but they need to have that amplitude signal, right? And so that's facilitated by these targeted muscle reinnervations, and so patients can regain some level of limb function. Let me quickly show you a successful outcome and one that's not. So this is a 54-year-old done at Jackson with a very positive outcome. So this is the transplanted nerve. It's within the muscle. This, in this case, is the pec. This is exactly what you want to see. The nerve going straight to the muscle. There's no scarring. There's no neuroma. The muscle itself is not atrophying. This is perfect. This is a successful TMR. Here's an example of an unsuccessful TMR. This is a lady that had a forearm amputation. Unfortunately, on the MRI, you're seeing these masses. That's indicative of a neuroma, but you can't really appreciate how well the repair site is. But look how nicely you see it on the ultrasound. Here's the nerve coming down. There's already atrophy of the muscle, so it's not getting innervation. That's bad. There is discontinuity at the anastomosis site. You're developing a neuroma, and there's even fluid there. This will not do well. This patient, there's nothing that can be done. This will not do well. So I just wanted to show you how we can really nicely assess these TMR patients, successful and unsuccessful. So with that, I'll end. So remember, familiarity with the location and innervation pattern will help you. It's really, you want to use MR and ultrasound together. It's not one or the other. Everything helps. And you have to understand as to what was done to the patient, and understand the healing process. And I'm sorry I went over time, but thank you very much for the invitations.
Thank you, Gene. That was terrific. I really appreciate it. We're going to have you back to go deeper into some of those points. And thanks for doing this. We'll have Kat tee her talk up.
Thank you very much.
So good morning. Today I'm going to talk about what Dr. Komatar and I frequently refer to as BPOV, or the better part of valor. And it's essentially a concept in neurosurgery which allows us to make better choices for our patients. And we'll go a lot more into it. But this is a very famous quote from Shakespeare himself, who said, the better part of valor is discretion. And at that time, I think he was referring to the quality of speaking in such a way as to avoid causing offense, or revealing something about yourself that you didn't want to reveal. Nowadays, I think the better term is that discretion is the freedom to decide what should be done in a particular situation. And I think in neurosurgery, a lot of us were drawn to this specialty simply because of that freedom, and that you are an expert in your field. If you think something should be done, you can make it happen. If you think it shouldn't, then you can say no, and that can be the end of the conversation. So I think there's a lot of truth to that is underappreciated. I'm just looking one more time for these polls, but I don't think it's going to happen. So anyway, whatever. Next slide. So because of this freedom in neurosurgery, it essentially creates the good, the bad, and the ugly. And I don't know if you're going to be Blondie or Angel Eyes or Tuco, but I think we all want to be Clint Eastwood when we start. And then things start to get in the way. Our choices get more murky. And you start to make decisions for things that you maybe didn't think you were going to in the beginning, such as RVUs, wanting to challenge yourself on a case, wanting to be more aggressive and try new innovative technologies and techniques. And ultimately, that can result in the transformation of you going from good to maybe not bad, but maybe a little ugly at times. And so that intellectual honesty and ability to check yourself is super important. And that freedom in our specialty definitely allows for this divergence of behaviors. So this is a famous sculpture outside of a hospital in Georgia. It says that basically valor is to have great courage in the face of danger, especially battle. That's their traditional meaning. But surgery is essentially a battlefield, and the tireless combatant is death. So I was gonna do a poll here. I'm trying to find it on my phone, but I can't, so we'll just forget it. So many studies have focused on this sort of battlefield response, this stress response. How do you handle it when things get intense? And there's so many, countless studies that look at heart rate, galvanic pulse response, you name it. And basically almost all of them find a correlation with immediate surgical error and worse patient outcomes, but they're all short-term studies. They are not looking at how that person went from second year to seventh year for neurosurgery and developed coping mechanisms to be better at dealing with those stressful situations and having their heart rate go down when the aneurysm ruptures or something like that. So there's a large need for that in neurosurgery. I think because we're having a harder and harder time picking who our applicants are going to be, because of the lack of step 1 scores, lack of grades in medical school, all we really have is to go off as presentations, publications and presentations at conferences. So, how good is that really a correlate for their success academically and surgically as residents? And so you start to wonder, like, what are the fundamental characteristics that you actually need to become a neurosurgeon so that you can one day become valorous and make the right choices in the OR and stop yourself before hurting someone, or not doing the surgery altogether, which is also the BPOV in certain cases. So we're actually doing some research here with Dr. Ivan. It's an Italian company called UpSurgeOn. They have these amazing 3D printed models that are really impressively realistic. And we're going to start it up soon. Basically, it's over a several week period. Junior level, senior level residents have different tasks, but they have to drill craniotomy. They have to identify anatomic structures, open dura. And this essentially is graded by an observer. And then it even measures like how you hold the instruments, things like that, your timing, if your craniotomy exposure was correct, if your dural opening was correct. And then it goes up to clipping aneurysms for more senior residents. And you are supposed to practice this over once a week over 6 weeks, which is relatively doable with res ed. So we're hoping to get this started soon. But then at the end of the 6 weeks, we can see not only did you improve in your technical abilities in these very specific measurements that UpSurgeOn has created, But then you start to think, okay, what can we do with this? There's so much research out there about, laparoscopic surgeries and tactile response and feedback, video games, all this stuff for other surgical specialties, but not for neurosurgery. And I think it would be very cool to start thinking of these kind of 3D models that are really realistic and not very expensive as psychological and emotional tests, and not just tests, but teaching moments for how to deal with stress. So open the superior sagittal sinus, and how do you deal with that, and how do you calm yourself down and go through the right steps, and then you do that again 6 weeks later and you're better and calmer and faster. And nowadays with the technology that we have with validated neuroscience techniques, you can do eye movement efficiency and have them wear glasses where they can look exactly where their eyes are looking in the field at all times to know if they're being efficient with their movement, economy of their hand movements. And honestly, one day, what if we did fMRI while we had applicants doing these procedures? I think that would be much more telling than their lack of grades from their med schools and no ranks and no step 1 scores. So I think in this changing future, we're going to have to figure out a better way to evaluate people. And I think this is sort of an exciting new future that we're going to work on here, and we are working on here. So there might be some ethical issues with an fMRI, but maybe the residents will agree to it. So we'll see. But how do we predict long-term success as neurosurgeons? Often people describe it as sports, athletic sports, which I think has some similarities. Focused attention, controlling one's emotions, the stress responses, staying in the moment, minimizing distraction, rehearsing the procedure in your mind, visuospatial processing, anticipation of complications or problems. And I don't think that's taught enough. If you have been an athlete, that's definitely ingrained in you. It's something you do all the time. But we often don't talk about, like, visualize the surgery. We might say, what's the next step in the surgery? But maybe a focus on some of these studies that are showing improvements in surgical timing, efficiency, outcomes in trainees after visualization prior to the case. So I think that there's something to be said about that. But I don't think athleticism alone is going to be predictive of who makes a great neurosurgeon. And this is another good study about the acquisition of motor skills by sports training and education, but it was applied for surgery. There's lots of them is the point here, but one that was particularly important was the medical students. And they were using robotic and laparoscopic technology. So we're not there yet in terms of the robotic, but we could be with the ROSA. So anyway, interesting avenues to explore, especially for upcoming interviews in the future when people can come back in person. Maybe we can start to challenge them in new ways. Yeah, the next topic is, what is the personality of a neurosurgeon that creates someone great, that's going to be able to make the right choices, do the right thing for the patient, handle distress, and under duress, make the right choice and not hurt the patient, and also in clinic make the right choice and maybe not sign them up for surgery. And so there's this concept that I didn't come up with this, but it is, preached frequently, that each surgical generation perpetuates a culture it passes on by recruiting residents who seem to resemble themselves, and then training these residents to emulate their thinking and their behavior. And so what you end up getting is a group of people that are all very, very similar. And this has been proven with a few studies. I know there's some issues with the Myers-Briggs study, but I found this fascinating. So I was going to have a poll and have everyone type their Myers-Briggs if you knew it. This is a breakdown of the Myers-Briggs personality survey. It's got 4 letters, E, I, S, N, T, F, or JP. And over here is the basic general population breakdown. And if you can look at the bottom, the INTJ is 2.1% of the population. So a study out of Cleveland Clinic decided to incorporate personality typing into neurological surgery residency program applications. And not just applications, but their actual residents and faculty who are already part of the program. So 11 out of 11 residents and 85% of the faculty were INTJ, which means introverted. You're thinking. The N is for let me go back. I can't remember the N. Intuitiveness, that's right. And then judgment. And so the concept of this person is like the mastermind or the scientist. And normally this is, like I said, is 2.1% of the population, but is 36.4% amongst the faculty and 100% amongst the residents. The other portion was E and TJ, which means an extroverted version of the same personality trait. And I think these traits are only interesting. It's kind of like horoscopes, where it just makes you start thinking about yourself and talking about yourself in ways you don't know how to do or haven't done before. So maybe you start to realize, oh, people who are able to intuit problems and see things a certain way, plan ahead, all of these features are described by these 2 personality types just that were featured in this study at Cleveland Clinic. But it's pretty remarkable that almost 100% of the residents were the same personality type. So I was curious what ours was, but we'll do that another day somehow. Then another thing that I found super interesting after the last, I guess, 2 years now of applications, being, Zoom only, is that we don't have a lot to base our decisions off of in terms of applicants. So step 1 score, class ranking, number of publications, which were all previously available, were not even that correlative with clinical and academic success. So actually, Edward Benzil's part of this paper, he had the idea to correlate personality assessments with these other normal selection criteria for residents that applied to the program. And there were no differences in the validated personality scores amongst all the applicants, which is okay, whatever. But what's interesting is that people who had a higher USMLE score over 260 had significantly lower imaginative score, which basically means a stress measure of eccentric thinking and then impatience with those who think more slowly than you. So imagine an intelligent person talking to maybe someone on the phone at Jackson who's not up to speed with how you're thinking, and your frustration with them is much higher. So that was an interesting correlation and was statistically significant. The next thing they found was that the average number of publications per applicant had a significant positive correlation with higher adjustment scores, meaning being more even-tempered, having better composure under pressure. So publishing more equals someone with better self-composure, essentially. And then there is a significant negative correlation between the number of total publications and the excitability or emotional volatility of that person, as well as their skepticism in terms of receiving feedback. And again, all of these were statistically significant and validated psychological tests. So I thought that was interesting. Maybe we can start to break these things down even more now that we have less information and used what we can from it. So now that we know some of the features that are good to be a valorous neurosurgeon, this is Lagertha, famous Viking. Not a lot of women Vikings, but she was one of them. And basically is famous for saying that I'm iron and I forge myself. So you start with something, right, in neurosurgery, some sort of personality characteristic that's beneficial for you. And then you have to be forged through a very long, arduous residency process that's designed to harden you and make you into a very sharp instrument for good. But in that process, you learn this concept of better part of valor, meaning essentially knowing when to stop, knowing when to say no, defining and respecting that limit ahead of time before you even start the case, which means you have to know all the steps of the case and the complications of it. So this is more something that happens as you become a senior, I think, but it's something you should start working on as a junior. And the number one thing about it is exerting self-control, no matter how hard it is for you to stop doing it. You want to take that last piece of tumor, you want that perfect post-op MRI, and you know if you do, you're going to hurt the patient. So you stop. That's the better part of valor. And it's a hard thing to do, and definitely something that I think should be respected over a perfect MRI. So in general, just the basic requisites to be a surgeon would be desire to minimize human suffering, the ability to actually inflict pain in order to alleviate suffering, studying for years, basic interest in your specialty, tireless perseverance and dedication to your own improvement, and the ability to make decisions. And now to be maybe a more specialized surgeon, you need to motivate those around you to achieve your common goal. Again, make decisions, act on them, and do not vacillate. Like, have a goal, have a plan, and make it happen. And others will follow and get things done faster for you. You need to be flexible, especially when things go badly, and have contingency plans. And resilience in the face of adversity, especially when you created the adversity. And that's something that you become more familiar with in time. But it's not easy and gets easier, but it's definitely a skill to have, and a skill you can only gain, unfortunately, by experience, which means messing up typically. And of course, lifelong learning for any surgical specialty. So if you want to be a neurosurgeon, though, you have to take ownership for your responsibilities. You have to maintain radical intellectual honesty, no matter how difficult it is. You have to remain assertive, resolute, and even disagreeable when someone's own agenda threatens your patient's safety. You have to be calm under pressure, and you have to be inquisitive and have a desire to advance your field with innovation and research. And you have to follow through on these things. And you also have to look like this guy, obviously. So I'm not sure if everyone knows what the Dunning-Kruger effect was, but I had a great poll. One was, of course, I know who Dunning-Kruger is. He invented ECMO and pedicle screws. The second option is, I have no idea what Dunning-Kruger is, and I'll never figure it out because I can't figure out sodium. The next is, I'm not sure what it is completely, but I don't really care. I'll get there eventually. And then the last one is that people who typically have the least ability tend to overestimate their ability and knowledge the most. So Dr. Wang frequently refers to this Dunning-Kruger effect, and it's definitely real. So to the junior residents, like, this is you. This is happening to you. It happened to me. It happens to all of us. You come in here, you think you know a lot. And the more you learn, you realize you don't know anything. And then you start to learn again. And trust the process. Be grateful that you're here. A lot of people want your job, like thousands of people. And you have one of the best jobs with one of the best program directors and chairmen you could ever ask for. So commit yourself to working hard. It will pay off. And this is just my shout out to the junior residents to remember that you have a special time in your life right now that you need to appreciate, and that you maybe don't know everything just yet. So the road to valor is lined with humility. So this is Don Quixote of La Mancha trying to fight a windmill. which is similar to a lot of quantroses that might occur at Jackson. And then another favorite quote of mine of James Blake, which is, you never know what is enough unless you know what is more than enough. And so that's part of that learning process where you take a step too far, you've crossed the line, you've maybe injured something or you've caused bleeding or whatever, and it's fixable, but now you know you can't pull that hard, you can't push that hard. And that's why it's 7 years, is to learn how hard you can push and win. So the next thing that I think makes a great neurosurgeon is somebody who's able to learn from every interaction that they have. And this includes all of these people listed here, which is a lot. Of course, your chiefs, attendings, senior residents, even your co-resident with 4 months more cranial experience than you. Definitely your scrub techs, your fluoro techs, Jose and Breton, and Tyrone will teach you more than most people ever could. Even your reps, your circulators, CT Jose, all of them, especially morning conference, M&M, and of course, the patient. So look at every opportunity as a chance to learn, be better, understand the system. And then when you get in a situation where you're struggling, you will have many more outlets to correct yourself and correct the problem than you otherwise would. So intraop, better part of Valor application, is essentially a guiding principle to do the right thing for the patient. So abandoning that gross total resection to save function and quality of life, relinquishing the satisfaction and the vanity of having a perfect MRI, accept the residual. You can radiate it if it's that type of tumor, or you can watch it. It's okay. They wake up okay. It's better ultimately in the end. And then it's a common saying, but when perfection becomes the enemy of good, this is a very common thing that a lot of surgeons fall into, especially neurosurgeons. And ultimately, this better part of Valor means knowing when to stop. So one part that I think is interesting is in emergency situations. Dr. Heroes comes to mind because of his teachings for us, but there's always kind of an element of paternalism when a patient has a terrible head injury or spinal cord injury. They are not really able to make any decisions. Their family is in extreme duress. They have no idea what their family member has actually suffered, right? So only you know that, and you're trying to convey it. It's really hard to, because they can't really hear anything past, bleeding around his brain or spinal cord injury. So I think that we often leave decisions up to the family, and I'm not sure if it's always the right thing if they're 80 and they have an acute subdural and their G-SIF is 4 with reactive pupils. I'm not saying you shouldn't offer surgery. I just think it's something that we should think about because no one can know what they're signing up for post-op to care for that family member other than the surgeon who sees it all the time. And they don't know what it means to take care of a trach and a peg at home and to have to deal with that forever. And not that they don't love their family member, but maybe that's not how their family member wanted to live, So I think it's a really important part of being valorous as a neurosurgeon to maybe sometimes not offer things that are futile. So in the pre-op or clinical setting, this applies as well because there can be very tantalizing cases, but there's no benefit to the patient. They have no symptoms. What are you going to achieve? How are you going to help them? You're not. So you resist and you get a surveillance MRI in a year. And it's a hard thing to do, but it's important and it's better off for the patient. Oftentimes we'll see people for second opinions mostly who've been offered surgery where we know that there's greater harm than benefit. And that's definitely something to avoid. This better part of Valor, do not offer that surgery. again, benign tumors that haven't been growing over years. They're not causing any mass effect, but it's sitting there. It looks juicy. You want to take it out. You have open time on Thursday, you know, resist that urge. Try to remain ethical, and honest with yourself about what's the right thing for the patient. And then these are more like debate questions, such as shunting leptomeningeal disease, given that they have a 4-month survival rate, shunting end-stage GBM patients, because now they can't pass from hydrocephalus, but now you've given them more time because they're treated hydrocephalus. So that's more of just a debate question, which we won't be able to do because of the polls. But the last two are super common. Pressure from oncologists to re-resect a tumor, a GBM, when there's no chance of a meaningful resection or meaningful recovery. And like stroke neurologists calling in the middle of the night for a thrombectomy or for an M4 occlusion on an 80-year-old with minimal stroke symptoms. So never underestimate the will of a non-combatant. That's super important and part of your job as a neurosurgeon, because you're the one who takes the risk. So the one thing that we do have data on regarding making emergency decisions with patients that are life-altering is for decompressive hemicraniectomy for malignant MCA syndrome for stroke. And it's actually quite interesting. Most meta-analysis found that 70 to 80% of caregivers said that they would retroactively consent again for the hemicranie had they been in that position again. So they don't regret it, 70 to 80%. The rates of, I should say, the rates were lower there when the patients were sorry, the rates of wanting to do the surgery again were higher when the patients were younger and the stroke was non-dominant. If it was dominant, the chance of the caregiver wanting to have the decompressive cranie again was much lower. But there's a lot of studies about that, which I think is an interesting topic. And then this is one other, which goes with what I just mentioned. There was a national survey of neurosurgeons and stroke physicians on decompressive hemicraniectomy for malignant MCA artery infarction. And basically, it said that 54% and 24% of neurosurgeons and stroke neurologists, respectively, would recommend decompressive hemicraniectomy for ages 60 to 70 and 70 to 80. But the really interesting thing is that stroke physicians were statistically more likely to recommend a DC in patients older than 60 and in those with a dominant multi-territorial infarct, both significant. And obviously the neurosurgeons were not on board with that. So that goes exactly to my point of never underestimate the will of a non-combatant and learn to say no. That's ultimately the better part of valor here. And because I didn't have polls, my talk it's over. That's all I got. So if you have any questions, let me know. But